Bismillah ar-Rahman ar-Rahim. Good evening, everybody. Welcome to Riyadh GI Club. Tonight, inshallah, the National Guard Hospital is going to provide the cases. We have, unfortunately, the attendance is not as we were expecting because of the bad weather, but hopefully, inshallah, with those attended, we'll have a nice time. We have three interesting cases. The first case is going to be presented, the first two cases are going to be presented by Dr. Maimoon. He's this, assistant consultant in the Department of Medicine, GI. And the case we are presenting, not necessarily we have a diagnosis. We presented to have to share with you their opinion, way of management. I thought it was going to be interesting. And so we are very happy tonight. We have Dr. Muhammad Bawaziri is a consultant general surgeon. He's going to be involved in the management of the second case. And we have Prof. Darathi from radiology who's going to help us a lot. Thank you very much. Maimoon, can you start, please?
Bismillah ar-Rahman ar-Rahim. I'm going to present two cases. First case, she's 20-year-old Saudi female, medically free, presented in ER with epigastrial pain and poor appetite for 2 months and hematemesis for 4 days. Epigastrial pain started gradually 2 months before. It was mild to moderate in severity, dull in character, almost persistent, non-radiating, aggravated by taking food. It was not related to posture, not associated with nausea or vomiting. However, it was associated with the loss of appetite from the beginning. She had 3 episodes of vomiting fresh blood over 4 days prior to presentation. It was small in amount, not preceded by retching or blood-free vomiters. She denied history of formal or current use of alcohol, smoking, NSAID or herbal medication. This all the list of review of systems. She denies any history, so this is not relevant. Relevant in a sense that it's just negative. Family history not significant. There's no family history of malignant GI tumors or bleeding disorder. And past medical history unremarkable. No bleeding disorder previously, no history of peptic ulcer disease, and no history of liver disease. Surgical and drug history is unremarkable. So just on the basis of history, patient history of 2 months epigastrial pain, which is mild to moderate, and it is persistent, and with anorexia, same duration, and 4 days history of hematemesis, which is small amount. No any findings, no any symptoms in the system review. So what might be the possibilities on the basis of this history?
A common thing is common. I mean, peptic ulcer disease.
Yes.
As one of the differential. Whether any other source of the bleeding like Delafoy or some unusual AV malformation. Then malignancy is still a possibility, although it's in the law with this age.
Okay. No.
As far as this presentation, it was mentioned peptic ulcer disease, AVM or GAVE or whatever, one of those angiodysplastic. And question was asked about any perioral PTK or anything suggestive of, what are you thinking, Doctor? Okay. So something hereditary or something, okay? I think let's proceed. So these are on the mind. Malignancy is on the list, but it's a little bit lower because of the age. Dr. Adnan? So Dr. Adnan is thinking of IBD in the stomach and mainly, I mean, Crohn's disease, gastric. That's good also.
Definitely, we will think of common thing first, peptic ulcer disease, on the top, on the basis of history. and persistent pain, and since 2 months with anorexia, we must think of the lymphoma malignancy. Mallory is unlikely based on history, but sometimes patient just come with gastritis, history of gastritis 2 months, and then vomiting, leading to the Mallory. Unlikely though. So
can I add one more, maybe less likely, but I think I should really raise it. Well, there are two things now going on. There is the pain and anorexia. Then 4 days before, she started to have a bleeding. So I think, could this be just pancreatitis or Haemosuccus pancreaticus? That was really, she has a pancreatitis before, chronic, and now it's bleeding in the PD, and now she's present with the bleeding. For pancreaticobelia.
Usually, Haemosuccus pancreaticus, it presents usually with melena more than really hematemesis. This lady, she did not have melena because, the ampulla is in the second part of the duodenum unless there's some reflux of the blood. So we'll consider this one as hemophilia or Haemosuccus pancreaticus for the bleeding from the pancreas bed. Okay, let's proceed now.
So next examination. General physical examination, as you can see, it's unremarkable. As far as system examination is concerned, also there's no findings. This is the initial labs done for this patient. It's showing the mild anemia, 102, along with low MCV and low iron, low ferritin, and with ESR 60 and CRP is less than 3.5.
Have those labs made any changes in the impressions or differential?
These are related at 60. With anemia, can be related.
Okay.
I don't think
So the two things pops up, microcytic, hypochromic, iron deficiency anemia, and the ESR is elevated. Otherwise, looks like we're dealing with normal lab profile. Yes, doctor.
CRP is normal.
Yes.
Sorry, what's important here that we have features of iron deficiency anemia. So if it's acute bleeding, a priori these patients, they have normocytic anemia. So something else, if I look like this, so celiac also should be ruled out.
So peptic ulcer disease, I think it's kicked out. I mean, I've never seen myself peptic ulcer disease, the one we all know that causes chronic anemia. I mean, most ulcers heal on their own 4 to 6 weeks. I mean, unless they get complicated or something. So then we will withdraw a couple possibilities. So we're left with malignancy and whether lymphoma or adeno or whatever. And we'll have the IBD and we'll have the AVM malformation or anything hereditary that the patient might have had. Okay? Go ahead. And what? Just? Yeah.
I had
Okay.
one 6 years ago.
Just? Okay. It's a possibility. It's neoplastic, I would say. I mean, if it's going to cause this one, it should be big enough to bleed. So, okay. So just another possibility. Go ahead.
Just upper.
So an upper endoscopy was done because it's our favorite as gastroenterologist.
Just show the other images also.
So if we can go back to the
I'll
first
go back.
slide.
Just
First one. Yeah. So.
Can you take the light?
Taking the image from the processor to the endobase and then again exported, we lost some of the features, What I can tell you, actually, I drew a line on there just to show you that there is nothing beyond distal to this line, and it's more proximal, all these bumpy, granular, whatever you see. So the antrum, it's pretty much spared, except a little bit of congestion, as we can see in the background, but there is nothing to the mucosa. So next slide, please. This is what we see in the corpus, from the lesser, incisor angularis all the way proximal in the anterior and posterior walls and all together. So the lumen, it looks like there's some structuring there, but it was easy to go with the scope. This is what we see. And then show us the other slide. This is the antrum again. We can see just erythema. Okay, the fourth one. This is proximally with retroflexion, as we can see. The cardia also is involved. You can see this bumpy mucosa and a little bit of atrophic background with all these things. So with any of our endoscopist comments on what does that for you? Would that change your differential or what you would consider? Narrow down our list of differentials. Yes, sir.
How about the esophagus? Any varices or any...
No, esophagus is normal. There is no varices, no.
Instead we'll go to our list to consider again involvement by lymphoma. Either mount lymphoma or just B-cell lymphoma.
Lymphoma starting from mount all the way up.
Yes, any type of lymphoma. And then I think still other granulomatous disorders like IBD, like sarcoidosis, very rare but can involve the upper, especially Crohn's. And TB is possibility, but less likely. No fever, no weight loss. She didn't lose any weight, by the way. She has no weight loss.
Basically, we can document in our chart that over the period of 6 months, there is only 2 grams drop. So only 2 kilos drop over a period of 6 months, but herself did not make a comment on it. So we're narrowing down the possibilities of lymphoma, different types, malignancy, and you said granulomatous, whatever diseases, which fits under a TB, Crohn's, sarcoidosis. Any other possibilities? Doctor? Mentrier disease is something on the list. Okay. Anything else? No, usually it's different, but it's... Okay. For the sake of time, we're going to roll over so we can get chance with other cases. Go ahead.
Yeah. So we come up with differential like Crohn's, sarcoidosis, Mentrier, lymphoma, malignancy. Mentrier's in this patient, though its endoscopic finding is not that typical, but what is against in that this young lady with 20 years old, usually it occurs in a middle-aged male. And apart from that, albumin of this patient, we saw it was normal. 39.
Was normal, yes. Okay.
This is the histopathology.
Yeah, unfortunately, we're going to get our own pathologist to come. So I don't know if there is anybody from pathology here who can... Yes? No? No? Well, then we'll make our own comments on it. Go ahead, Yusuf.
So just, you can appreciate here on the lower green arrow, there's a granuloma, non-caseating granuloma. And the upper arrow, fibrinoid...
down at 5 o'clock, which is the granuloma.
Yeah. And the upper arrow is the fibrinoid necrosis of the small artery. With further, on this basis, what are the differential now?
So we have a vessel and we have a granuloma. So the vessel, basically, we're talking about small vessel vasculitis in this one. Yes, so we're talking about, and here's another...
Special stain, elastin...
It's elastin staining, okay.
Showing the damage to the ring of the elastic, this arterial valve, and same granuloma there.
Yes, damage around like 10 o'clock of that vessel there. So we have vasculitis, granulomas on the biopsy. Okay? Next. Any next? Okay. So this is the interpretation of the pathologist in our facility, which shows granulomatous gastritis with vasculitis. Negative for HP, negative for lymphoma, there's immunohistostain and CD, negative for TB, Ziehl-Neelsen staining, and the elastin, which shows basically the vasculitis. So we have granulomatous gastritis with vasculitis. Anything now, what would you consider in this scenario? 20 years old with these odd-looking granular-like mucosa with some infiltration to the gastric corpus, up proximally, antrum is spared, no varices, nothing in the duodenum. I think I've taken also duodenal biopsies on her during that, and which was negative, basically. So now, what would we have in our differential? Yes, doctor? Sarcoidosis is Wagner. Polyarthritis nodosa.
Some virus disease, like cat scratch.
Cat scratch disease in the stomach.
It can be. You have only 16 that don't have you.
خلاص. We'll take it. Okay, we'll take it. Okay. So it mentioned Wagner's sarcoidosis, cat scratch disease. What else you mentioned? Polyarthritis nodosa. Behçet's can cause vasculitis, but it usually doesn't have the typical amyloidosis. I haven't seen one, but so
I think
we'll go over the differential.
Focus on the granulomas and vasculitis or granulomatous gastritis. You can say this is a granulomatous gastritis. Polyarthritis nodosa usually doesn't have the granuloma. It's just affecting the.
Doesn't have granulomas. Polyarthritis nodosa doesn't
Yeah.
have. Okay. Arthritis, poly.
PA.
Arthritis.
Arthritis.
Yeah, the one that polyarthritis.
Yeah. PA. So the conclusion from histopathology is the granulomatous gastritis with evidence of vasculitis. So differential, what we already discussed, Crohn's, tuberculosis, sarcoidosis, lymphoma, vaginalis.
Okay. So what we've done for this lady to sort through these possibilities. Okay.
To rule out the sarcoidosis, we did the S level, it's normal, and calcium is also normal for this patient.
Okay.
CT chest we'll just review in a while, and for Crohn's, colonoscopy done to see the TI and the colon, it's normal including the tummy ileum.
Okay.
This is the CT chest, and we honored Dr. Professor Dorothy is with us to just give her impression on the.
Good evening. Our case is made very easy for us. I wish all cases come like this, all worked up. And in this situation, all we need to do is now to find out whether there's other areas in the body which dictate TB or Wegener's granuloma or sarcoidosis or whatever it is. But I can show you that this, here at least you can see there are no hyaluronopathies to indicate sarcoidosis, because that's the hallmark of sarcoidosis in the lungs. We don't have that, even no interstitial fibrosis, nothing. Then when you get to the stomach and you scroll it down here, the fundus is quite normal. The spleen is not enlarged. Liver and all these areas, there's no lymphadenopathy in the abdomen to indicate tuberculosis. Can you see the next one? Let's see. Now here again, here, this is the stomach. This is where the problem lies. This is normal liver, very, very nice spleen. And the fundus of the stomach, and as you come towards the body, can you see how thickened it is with irregular mucosa? Show you the next one again. Now, go back again. Here, can you see this is the body of the stomach, very thick, concentrically thick. And the pattern, it's not like malignancy, it's so smooth, very concentric. And again, all the other organs are normal. So it's just a limited area, and it just simulates what he told you in the endoscopy. Like you can put a ruler behind and below where the narrowing and constriction is at the body. Go again. And again, just to show you, again, nothing much. You can see no lymphadenopathy. And then in terms of Wegener's granuloma, the kidneys are very normal. Very, very normal. No lymphoma. And then, okay, oh, that's a beautiful one. Have a look. Can you see the constriction? Very, very nicely constricted in this area, and that's where the disease was. So the imaging basically excluded sarcoidosis. There was no other area of bowel disease in the small bowel to indicate Crohn's disease. No other stigmas of Wegener's granuloma. So,
Thank you, Dr. Dorothy. So according to the imaging we've had, you've heard what comments she made. So we'll proceed then what we've done also. Just to summarize it up, there was also TB BCR done on the biopsy itself that came back negative. The TB culture on the tissue itself, as of now, it's negative, although it takes up to 7 weeks to get the final. So basically, what the P-ANCA came back.
We'll show.
You showed it or no? It's coming.
It's just
So,
a
so the
brief,
P-ANCA also came back negative. The urine testing, urinalysis came back as negative also.
C and also negative. C and P both negative.
Both of them negative. So pretty much the Wagner's disease is out. Lymphoma with the immunohistochine and CD, it's out.
Yeah.
TB, as of now, I don't know the PCR, it's not really very sensitive, but stains, culture, yes. They did the CD staining, CD on the biopsy itself. About the lymphoma, Dr. Jibrin said lymphoma is not ruled out.
Mr. Pathanaj, they just did the two things like H&E staining.
Well, actually, endoscopy was done twice. One time, and then it was repeated. We took big chunks. I mean, I just made it bleed really well. So 2 times upper endoscopy was done. Yes.
Immunohistochemistry and this H&E stain.
Yes, sir. Yes.
So on the basis of immunohistochemistry and the H&E stain on the biopsy, lymphoma is negative for that. So just granulomatous gastritis, which is quite rare, and those developed countries, when they have the causes like non-infectious more common, and the developing countries, they have the infectious causes more common. So non-infectious like Crohn's and sarcoidosis on the top, and infectious tuberculosis on the top. Just a few of the from the list, and 25% of cases, the granulomatous gastritis comes as the idiopathic granulomatous gastritis, which is even challenged that whether the IgG really exists or not. So our patient has non-chelating granuloma along with the elements of vasculitis in stomach. Vasculitis workup done, it's all negative. Urine analysis, there is no cast and no hematuria. Hepatitis B and C is negative. So what is the conclusion now?
So narrowing down the possibilities now, we're left with one entity, which is Crohn's disease as number 1, and number 2, idiopathic granulomatous gastritis. And so this case is just fresh, actually. We did it last week. So we thought about presenting it to you because we want to hear from you. Where should we go as far as of treatment in this lady? I mean, Crohn's and idiopathic TB pending the culture now. How would you go on what to do next?
Thank you. Sorry, I missed the first part. But how common you get like an upper Crohn's without any other small intestine or colon involvement?
It's not common, but in my experience, I've had 2 cases before, and if this is to be Crohn, it's the 3rd one, isolated gastric. Myself, 2 confirmed one, I've treated and nothing. Yes. Yeah.
5% Crohn's disease can be limited just to other.
Yes. So myself 2 in the past, and this one might be the 3rd one. So for us now, we're still debating what to do next. Are we to treat like TB, given ourselves that we are into that category of the world, you know that? I think TB is probably. Yeah. Or go straight and treat for Crohn's disease. Any inputs or?
Doing EUS because I was very impressed with the CT scan with that thickened, like there is a hump. Yes, have you thought of doing EUS and deeper maybe biopsies? Because have you seen the CT scan is really very impressive for that, just like maybe 4 or 5 centimeter hump on both sides. And the other thing for Helicobacter,
yeah, it's really structuring. I mean, but the scope, I mean, gastroscope went easy.
I think I should really do US. The other thing is for Helicobacter, I hope you have taken a biopsy from the normal looking mucosa, not from just that pathology, because it will be negative.
I've taken from the underarm, as you see on this.
So it was negative.
And
But
I've
this is
taken
my.
from the duodenum and even the bulb, because I was thinking of even celiac. And I've taken from the one that is.
So the HP is ruled out.
Yeah, ruled out HP, yes. No, I did biopsy. She's not in PPI, and it came back negative. So,
lymphoma, especially with this very significant. I might do actually use an FNA deeper. Probably it's a Crohn's. Probably it will end up as a Crohn's and steroid might, or idiopathic. Idiopathic, we don't know. Most of the idiopathic we call later on, we will know the diagnosis later, but we call it now idiopathic. But with that going to be Crohn's, I might actually consider a US with FNA of the submucosa.
So,
yeah.
Should we go for?
I agree with Dr. Rahman. We have to get all the tests of H. pylori, all invasive and invasive, because sometimes those patients they get PBI, and that's all the CLO test will be negative. Histology sometimes difficult to see the organism, and also confused with other type of gastritis. So probably you would do all the other tests of H. pylori, like for example stool antigen, serology, or the rest. And I'm not sure about the trial of treatment of like an H. pylori, if it's like in a positive or negative, and then you think about lymphoma, and probably maybe it's a Crohn's disease.
This is unlikely to go with the H. pylori treatment. This is not even the type of granulomatous gastritis we see with H. pylori. Most of the time with the granulomatous, we see a little bit, not like this. This is very thickened, lumpy mucosa.
Further rule out of HP and give deeper tissue for slim possibility or any possibility of
Lymphoma. I mean, that's a two
anything else
possibility.
before the ASCA, we did not do the ASCA. I mean, we have it available. We're talking about this afternoon if it's going to add any more. But we did not order the ASCA. This is what anti-saccharomycin.
Yeah, as I had two cases limited to the upper tract. I had one within and one within and the other one, I had one jejunum also. So we can consider the ASCA and all is there. Anything in control.
You are thinking logically. You are all physicians. There are only six conditions in the pathology that gives a granuloma. Lymphoma is not one of them. Granuloma, non-caseating granuloma, TB is unlikely, but it could be. So somebody who got a normal chest X-ray, that will exclude for me probably the TB and the sarcoid. Okay, no highland lymphadenopathy. You can get secluded TB anywhere, but if there is a seclusion to just the stomach, Crohn's is more likely than TB. Crohn's can occur from the lip to the anal canal. It could be soli, it could be gastrointestinal. The lady was very well, then she got a disease only for 1 month with no appreciable loss of weight and so on. So I am still thinking that it will be the idiopathic granulomatous gastritis. It will not be something else. But of course,
You think it's idiopathic?
yes, it will not be Crohn's. And you already had a pathology and you took it away. And you took all the investigation. And it will be the idiopathic.
So,
I think lymphoma can cause granuloma. Lymphoma can cause granulomas, yeah.
yes, granuloma.
So this is why it was brought up, although we did not have the final. So now we're thinking Crohn's, as the list says, and then, so we're going to go and dig into what you suggested, but at one point we have to make a decision about where to go next because she's symptomatic, this lady. So, Dr. Hauser? It's the whole wall. I mean, as you look at the CT, the whole wall is thickened. Yes. Yeah, when I biopsied, I mean, I took deep like well one, I just... No, it's just... if we can quickly go before we finish this case, just show the image to the...
You want endoscopic image?
Yes. Okay, Dr. Duff.
If you shut your eyes, and I show you, if I, it's body here. I just, bring the pictures again.
X-ray.
Yeah, the pictures. Okay, let me scroll. Okay, just on the next one. Now, if, no, not that one, this one. Not this one, this one. Now, if I show you, if I say that this is not the stomach, shut your eyes and think about the small bowel. If I show you this picture on the small bowel, what's the first diagnosis you'll make? Yeah. Okay, I'll show you the next one again. One that is really this one.
Yeah.
This part. If I show you this kind of narrowing in a small bowel or a colon, what's the first thing you will say?
So
Dr. CMS, we'll update you on her in a couple of months, inshallah, about what we take for this.
So we come up.
Very second wall, and especially in the tubes, and all biopsies were negative, and all things. And when they did USFNA, they took a biopsy from a nearby electronically signal cell.
Just from the
Yes.
So it was Lineitis plastica, probably.
No, not nice, but just signal cell ring.
You said the whole stomach was involved.
Yes, the repeated biopsies were taken.
Yeah, I mean, this might start as Lineitis thing with signet cell recirculation. Well, thank you for your participation. We'll let you know an update.
Thank you very much. Thank you. That was a good case. The second case is really interesting, and we have Dr. Mohammed Bawazir is a consultant surgeon, trauma surgeon, isn't that right? He joined our hospital recently. It's a terrifying case, really something you should just keep yourself ready for the action. Can you present, please, more?
Yeah.
It's not liver.
So for the previous case, I think we should proceed for the MR angiography or capsule endoscopy, just follow with the patient for Crohn's or lymphoma. Second case, this is a combined case for the GS and GI. It's a 14-year-old Saudi girl, medically free, presented in ER with epigastrial pain, vomiting and constipation for 3 days. She was all right 3 days before presenting to ER. Problem started when she took dinner outside. On that night, she took heavy dinner, which was not usual for her. Usually, she avoids to eat more. Around 2 a.m., she started vomiting along with mild epigastrial pain. She was seen in private clinic next day and treated as gastritis, but she didn't get much relief, and frequency of vomiting increased and couldn't tolerate orally. Also, she developed constipation and couldn't remove the bowel from second day. Third day, she was brought in ER. In ER presentation, she was conscious oriented with the GCS 15/15, but looks very sick, dehydrated, tachypneic, and in moderate pain. She is tall and thin girl with height of 170 centimeters, BMI 15. She is not jaundice or anemic, no clubbing, no leg edema, and no lymph nodes. A look at the vitals. Pulse is 155 per minute, blood pressure 97/52, respiratory rate 46 per minute, and afebrile. No significant system issue, denies any weight loss, fever, cough, any skin and joint pain, no diarrhea. Family history not significant. All her sisters and brothers are tall, as is her father. Past medical history is also unremarkable. In abdominal examination, there is moderate distension of abdomen. It stands with mild tenderness, dull on percussion, bowel sounds sluggish. Other system examinations are unremarkable. Musculoskeletal system, there are just few findings to share with you. As I mentioned that she is tall and thin, and she had mild hyperextensible skin, but no joint hypermobility. Hands with long fingers and positive wrist and thumb sign. as demonstration in the pictures. She doesn't have any flat foot or hammer toes. But in the ENT examination, she has high arched palate. The rest of the examination is normal. Let's look at the initial labs in the ER. She has the significant leukocytosis, along with lactic acid is quite high, 6.8, altered coagulation profile, and serum amylase is more than 1000. ESR and CRP is also high.
Thanks for inviting me today. It's a real pleasure to join you. So we had this poor girl who came with a history of 3-day vomiting. She was diagnosed with gastroenteritis, sent home, and then came back with really in a bad shape. She had peritonitis, septic shock, hypotensive, tachycardic. As you can see, her lactate is 6.8, pH 7.1, INR is 2.9, white count 24, total bilirubin is 26. Very, very bad shape for a little girl like her. So when we saw her at this point, chest X-ray was not really, or abdominal KB, not really impressive. So differential diagnosis that you can help us with at this stage. So with the amylase of more than 1,000, my differential was pancreatitis number 1. And pancreatitis is very well known that it can present with peritonitis. It can give you this picture. There's no question about it. Other differentials like perforated peptic ulcer, perforated stomach, perforated small bowel, any perforated viscous can give you the same picture too. So we were talking about either we take her to the OR and explore to see if she has a perforated bowel. Maybe we do a CT scan first to see whether there's pancreatitis or not. And I think.
Have you thought of
Of course, yeah, that's.
She has a Marfan syndrome, I don't know if it's association with.
Yeah, this is very smart thinking from the get-go. But we are surgeons. We didn't think about Marfanoid features. Absolutely. So, volvulus and perforation of the stomach and.
You don't see the bowel
So this goes with ascites. Oh yeah, absolutely. Please.
Yeah. Thank you very much. Thank you. I think this abdomen is very interesting. This abdomen, you look at it, is absolutely gasless. It spells disaster. It can be disaster either because the person is dead, so he's not breathing. There's no gas in the abdomen, right? It could be because it is vomited so much that there's no gas in the abdomen. It could be due to severe colitis, because it's the colon that causes a lot of gas. But this one alone, it could be pancreatitis, severe pancreatitis. A gasless abdomen is a serious abdomen. That's number one. The other one that he showed is one that gave the story. Here, in the decubitus projection, there is extraluminal gas. So that now tells us this severity is due to perforation. Here, this one. And it's very small, very slit-like, very, very well. And with the clinical symptomatology, it's not difficult to know that this is a severe abdomen and that the perforation is upper, is proximal. That's why there's no gas at all. And there's no gas at all doesn't mean that there's nothing in the bowel. It means there's a lot of fluid in the bowel. Fluid. Because fluid, no gas, will cause this kind of ground glass pattern. And then we did CT. Sorry, I let you continue.
So there was ground glass hairs all over the abdomen, dispersing the bowel due to the severe peritonitis. So this summarizes this already discussed by Dr. Bawazir. The patient presented with acute abdomen with the condition of septic shock, with high amylase and acidosis. Possibilities already discussed. So acute pancreatitis, intestinal obstruction out of question here with this any ruptured appendix or any ruptured viscus from the GI. And there is definitely peritonitis and features of ascites even on the examination plus on the X-ray. So a patient was in a critical condition. ICU team was involved from the beginning. Initial management included resuscitation with IV fluids, IV antibiotics, correction of acidosis, and urgent CT scan abdomen done before proceeding to OR.
Okay. Yeah. Right. This is a CT. This is a CT examination that was performed. And these are the proximal cuts, and you can see that this child, if you remember it's only 14, this child, this is supposed to be, there's an esophageal tube here in the esophagus, and this is all reflux because the child, nothing is going down right here, right? This is the esophagus, this is pleural effusion, and if you look at right at the top, that's this whole big thing is the stomach. There's a leak coming out here, and you want to identify that the gastric wall is void, is absent. Why doesn't it have a wall? This is a spleen, there should be a wall here, is absent. You start wondering what's happening. Next cut, again you can see fluid in the peritoneum, air fluid level, and as the stomach again, there's no wall. All you can see there's an esophageal tube, beautiful pancreas and spleen, and gallstone there. The next cut now. Now the next cut, you see again there's fluid around. Again, you're not seeing any wall. Now you start seeing a bit of a wall, duodenum and some wall coming out here. The stomach is still, have a look. Aha, now you can see a gastric wall. Can you see that? This one has no wall, very thickened. So the fundus and the body very thickened. The antrum has similarity of a stomach with wall, little minimally thickened, ascites, fluid, and bowel loops. And I have a look. Again, you can see thick wall or part of the body, and this part is okay. Air fluid level. And look at bowel loops are all a bit, more or less collapsed, but appear thickened. Ascites. Look at the IVC. What does this IVC mean to you? Anybody? What does this IVC mean to you? This is the aorta, and that's the IVC. Looks like a slit. Absolutely sure. This patient is hemodynamically very unstable. Look at the IVC. This is shock. But we continue to do it very, very, very quickly. Again, bowel loops collapsed, ascites, large volume ascites. You can see the fluid level. So with the things in the stomach, no, I mean the fluid. Yeah, pouring out from the stomach. I mean, for the examination, maybe they gave him some more fluid and he was just pouring everything out. So this is why I was calling it ascites. It's fluid. And again, and now you can see the pelvis, the layering. This is the one we gave him. This is his. So everything was just pouring out. So in summary, you have a 14-year-old child who came in. Plain films showed very bad, very, very severe abdomen with perforation. The CT confirms that he's perforated in the gastric fundus. The gastric fundus and body, the wall is void, is not enhancing, meaning that when a wall does not enhance, it means it's dead. Okay, and then the other parts are enhancing. So that's the profile with lots of things in the peritoneum.
Looking at the pancreas, the high amylase will be due to the absorption of the fluid in the peritoneal cavity. not new pancreatitis. You see there is pancreatitis there? Is it inflamed pancreas or?
Okay, this is also a very good one. This is the gastric fundus and body. This is the antrum. Can you see? This part has wall. This one has no wall. All you have is just fluid. And these are collapsed bowel. These are collapsed bowel lobes. And this is a fluid in the peritoneum. And if I scroll back, oh, this is all still fluid layering in the pelvis. You can see how this is just the child's uterus and ovaries hanging in the fluid. And go up again. You are talking, the pancreas is as innocent as anything. Look at that. This look. Yeah. Look. Nothing to say about the pancreas. And that's the splenic vein, that's the portal vein. Nothing. Pancreas is normal.
The family history was not significant at all, no. So just keep in mind, 90% of the time, we do not get extremely accurate interpretation of images like this. Seriously. So most of the time, we just deal what we have. We have a patient with free fluid and free air. We just need to go to the operating room. Now I just realized that we made an intraoperative diagnosis just before taking her to the OR. She made it.
But we didn't ask her.
Okay, please proceed. Can you please
so now, by now it's obvious that there's a perforation of the stomach from CT imaging. So in the OR, light.
So what you're looking at, I don't have a laser pointer, I'm sorry.
Can you give me the pointer?
Pointer.
Can I borrow your pointer for a second, please? Thank you.
Center is a pointer.
Thank you. Can you go back one, please? Yeah, thank you. So what you're looking at is the head is here, the legs down. This is the stomach. What we found is exactly what the Prof said. We have ischemia of only the anterior wall of the stomach. This is her antrum. The duodenum is here, and with frank perforation. There was food particles inside the whole abdomen with free fluid, acidic peritonitis. So I had to call Dr. Zahrani as I did an intraoperative consult because this is not very common, and I had to take a second opinion from a senior surgeon. So we discussed the images over the phone, and we discussed that the best thing for this patient. We had two options: either do a total gastrectomy, which is not a good option for her because of her age. Second option is the best is always to do a wedge, and the stomach is usually friendly for doing a wedge resection because it has very good blood supply, and then you can put things back together, and then patients do fine. So what we did is actually wedge resection. So the body, the head, go back please. So head is here, legs here. So we resected the anterior wall of the stomach. Now you're looking at the posterior wall through the stomach. These are patchy areas of ischemia. I think this is only mucosal ischemia, because if you look at the posterior wall of the stomach, it was healthy. So I thought that was the best option. Just take out whatever dead in there and leave whatever questionable and healthy. And if you, and then we had to mobilize the greater omentum, and then we closed the hole. It was a really big hole, and then, alhamdulillah, everything came back together. So at the end of the procedure, we thought that, shall we do everything at one stage, just close the abdomen and then call it a day, or let's bring her back for another stage. I thought because of the mucosal ischemia in the posterior wall, probably better do it in 2 stages and do another intraoperative endoscopy at the second stage to make sure everything is going the right way before we close the abdomen.
So it was obvious gangrenous anterior stomach valve with perforation and partial gastrectomy with wedge resection done. Abdominal wall was kept open for second look after 48 hours. Temporary abdominal closure done. This is second look laparotomy along with the intraoperative endoscopy.
So she at the interim, she went back to the ICU. She was resuscitated with fluids. She actually did well. She was off pressors by the next day. She was making urine. She started to wake up. And then when she had a good blood pressure, we took her back to the OR, and Dr. Jihani joined to do the intraoperative endoscopy.
Yes, finding during endoscopy gastric mucosa around the suture or necrotic edematous with dark red color. And jejunal tube are placed for feeding. This is the endoscopic finding.
$48 hours, isn't it? 48 hours? Yeah. This is the, we are scoping the OR when Dr. Muhammad was there. I thought we second look at it there. You can see clearly where's the pointer. Yeah. This area doesn't look like healthy at all. It's just remnant of ischemia. So I wasn't really happy. I talked to the surgeon, he was with me, I told him, I'm not very happy with that area. It looks like, doesn't look like healthy because it's sloughed. The color is husky color, bluish, probably some element of ischemia is going on there. And the final decision was just to keep her on.
I think these are the actual mucosal ischemias that we saw the first operation, and it was sloughing out. And I was actually happy to close the abdomen at this stage. Alhamdulillah, we give her. We did not resecting yet. So the stomach AA from outside was looking healthy and has a good blood supply. We give her a jejunostomy feeding tube because I thought this is going to take a while to recover. We had to rest the stomach, and then we closed the abdomen permanently.
Can you go back? How can you go back? This area?
This, to me, better than the one in the top.
Yeah, all are.
The one on top is really. You're afraid from these colors of dark or black or.
This one.
And especially when you get the mud like inside. This is really very bad because we see that sometimes with people who's corrosive or something.
True.
So this is all mucosa.
Sloughed mucosa.
So that's once it's mucosa, I think it's gonna heal.
Yeah, this is what happened actually. We see it from inside. The surgeon see it from inside as well as outside. The outside doesn't look like very bad, isn't it? So we thought that probably the mucosa will be sloughed off, and since the stomach has a very good blood supply, there's a good chance that she will heal. And this is what happened, alhamdulillah. I think, alhamdulillah, she was discharged in that patient. She went home?
Yeah.
She went home.
The reason was why she got like
This is the issues.
So everything we, in retrospect, so when we saw her, so what was going on, the only thing that I could think of is probably organoaxial volvulus, which caused ischemia for the anterior wall. So what is causing the volvulus? So Dr. Mamoon has very nice pictures about the, you can take the picture.
Go back. So the outer wall of the stomach was quite healthy according to surgeons, so it was closed with the hope that this mucosal sloughing it will heal. And patient was under surgical ICU care for approximately 2 weeks and then shifted to ward. After gastrographin study ruled out any leaks on day 12, she was started on clear liquid and then gradually to normal diet. This is the gastrographin study. There's no leak, though it's irregular because of this edematous. Actually, she had the marfanite feature, but when we did the echo and the eye examination from ophthalmology, there was no dislocation of the lens, and aortic root was quite normal. So Marfan syndrome was almost out, but she is marfanoid rather. When we see a patient with marfanoid, We should think of homocystinuria also because they have marfanoid features with the chances of increased thrombosis, arterial or venous thrombosis. So even we did the homocysteine, it was normal. And volvulus, as Dr. Bawazi told, is on the top of the list now. Even the genetic consultation was done and their finding was same in the musculoskeletal system, and they requested some genetic study for this group of like Ehlers-Danlos or the Marfan. The result will come after 3 months. Ophthalmology checkup done, echo, vasculitis workup also done partly, and homocysteine level is normal, protein C, AS and endithrombin 3 also normal. This is regarding gastric volvulus. It is characterized by rotation of the stomach along its long or short axis, leading to variable degree of gastric outlet obstruction, which may present acutely or chronically. If it is more than 180 degrees, then it can cause the obstruction. It could be idiopathic or could be secondary. I'll go quickly because we have other cases to be presented. Just this figure, Dr. Bawazi, you can further elaborate.
The volvulus has two types, as everybody knows. It's the organoaxial along the long axis of the stomach, where the stomach rotates on the long axis, and the mesoaxial when the stomach rotates along the short axis of the stomach, or maybe combined. This patient may had a combined because it was only confined to the anterior wall of the stomach. The rest of the stomach was actually fine, and I still don't know. Everybody is just giving theories about what happened. We're not actually sure.
Any questions, any comments? Okay, so I think the credit for this... Yeah?
Was it a big meal she ate that prompted
We don't know. We don't know what exactly happened before that. But most probably she had like valvulus and perforated. The credit for this case should be given to the surgeon who picked the case, and he managed it very well. Thank you, Mohammed. Thank you very much. One more very brief case.
Yeah,
sorry. Very brief case. This is going to be very brief case. The last case is going to be briefly, it's not going to be a long case. It's going to be very brief, and just again, we need your opinion about this case. Thank you very much. Khalid, can you present Chaban?
I presented two brief. Assalamu alaikum. We have this 21 years old Saudi lady presented with a history of weight loss. She had a significant weight loss, watery diarrhea over the last 2 years. Since the last 2 years, she's weight dropped markedly from 64 to 32 kilograms, associated with nausea and vomiting, and little bit less loss of appetite. She had on-and-off diarrhea about 4 to 3 times per day. She denied any blood in her stool. Sometimes complaining of arthralgia, joint pain, shoulder, hip, and back. No fever, no night sweat, no dysphagia, heart pain, other symptoms are remarkable. This is over 2 years. She was seeking medical advice many times, mainly in private health centers. She was treated for amenorrhea by the OB-GYN. 7 months ago, she also was diagnosed with depression. She was getting depressed from all of this. She is taking antidepressant medication and minimal response. That's all what she got. Surgically, she had no clear surgical history. She's on multivitamins and antidepressants. No other drug history, no blood transfusion, not allergic to any food or anything. Family history is clear, no significant family history. She's non-smoker, non-alcoholic. The travel history is also insignificant. On examination of this lady, she is conscious oriented, underweight, dynamically stable. There is no clubbing, no lower limb edema, no large lymphadenopathies. Her abdomen was soft, but what we found that she's having ascites. There's minimal tenderness, but find that the patient's having ascites. That was the weird things. Her chest also, there was dullness, percussion of her chest, decreased breathing, most likely she's having pyloric effusion, cardiovasculars are remarkable. Skin examination, she has psoriasis on her knees and her elbows. So in summary, we had a 21 years old medical free patient with clinical history of weight loss of 32 kilograms, decrease in appetite, watery diarrhea for 2 years, arthralgia. She's having ascites and pyloric effusion. So what do we think so far? No fever.
Any suggestion about the initial possible diagnosis at this stage? 2 years sick, wandering around many clinics in Riyadh, treated with amenorrhea, depression, but she lost more than 50, like almost 100%, more than 50% of her weight, and she's still sick. And anorexia nervosa, anything? Celiac, xenophilic, IBD, Crohn's. Okay. Sorry. Okay. Neuroendocrine, but usually don't have it. We have very bad diarrhea. Lymphoma for 2 years, a little bit odd. Yeah. Sure. TB, possibility, but usually for 2 years without fever, possible. Yes? Okay, so this way of thinking regarding this case. So what we have done for her?
Regarding, she was seen by psychiatrist. She's losing her appetite. She's not refusing to eat. That I want to make sure about. Her CBCs, we done some tests. Her CBCs, white blood cell 7.5, is normochromic, normocytic, her blood test is fine, MCT is good. That's what we got now. So the albumin was very low. Albumin was 15, was low total protein. Was also had low calcium. Other liver profiles are remarkable. Liver function is also, and electrolyte was acceptable. We have a low vitamin D. Fecal occult blood is negative. Quantiferon test has been done, it's been also negative. Vitamin B12 is good, and the TSH is little bit screened many times for the thyroid function, was good. ANA was done, is negative. Celiac screen was being done, also it's been negative. Anti-transglutaminase is also negative. And GARDI also screen for GARDI is also come to be negative. So what do you think?
Sorry? You go for a scope. Okay, so what we did, scope or
we did with CT scan.
CT scan first?
Yeah. We had done
I think we did a scope first, but after that, but that's okay. The sequence of events, we did colonoscopy, then we did a CT scan.
Let's go to the scope.
Yeah, it's okay. I just think
Yes, scope. Yeah, let's go to scope. This is your scope, Dr. Mishak. This is your scope.
Okay. So that's the scope. You can see clearly that the vesical valve area is not normal. There is ulceration and granularity, and the rest of the colon was perfectly normal. We tried to go through terminal ileum. There was marked narrowing. Can you see the next picture?
Yes.
This is the vesical valve area. It doesn't look like a healthy at all. Can you see the next one? Yeah, this is the very tight narrowing of the vesical valve. So we couldn't go through. We took a biopsy from that area. Okay. So we did also a CT scan for her.
Yeah.
Okay.
So,
Prof, please.
We did the CT scan.
the pointer. Pointer, please.
Pointer. I hear all your differentials, so I'll try to exclude some of the things we are thinking about. I think the first, I had somebody say malabsorption, and I think we also thought about that. And in imaging malabsorption, we do not see specific features of celiac disease. The reason being that that's a big spleen. In celiac disease, you get hyposplenism because of the degree of poor nutrition. And stomach, you can see, is normal. This is how a normal stomach looks like, unlike the other one. You can see that the spleen and the liver, they are all good. And when you get to the bowel loops, can you see, this is thickened. Can you see concentric thickening here? Colon is full of fluids. Part of the portal vein and part of the pancreas are okay. This is the IVC. This is squashed. The abdomen, I think he pictured it kind of squashed. Kidneys are normal. Let's go down. Again, you see fairly thickened small bowel loops. There, all over. And go down again. Go down again. Okay. Yeah, I like the coronal views. The surgeons like the coronal view because that's how they see the patients, lying down. So that's the overall profile of the patient's stomach. You can see colonic loops with gas, small bowel loops thickened here. All these are small bowel loops. Some lymph nodes in the mesentery, homogeneous along the mesenteric roots. Now, when you get towards the iliac section, these loops are getting more concentrically thickened. There's ascites. In fact, the ascites is large volume ascites because proximally there's also a lot of fluid. And you go down there, and you had Dr. Johani mention that he couldn't get down to the ileocecal region. It was tight. Can you see this loop now? Now, this loop is concentrically thickened. There's creeping fat in this area. Mesenteric hypervascularity is beginning to give us a signature of Crohn's disease here. Here. Have a look there. And that's another very thickened ileocecal valve there, creeping fibrofatty changes, and ascites again. So on the overall, we see lots of thickened bowel loops. We see definitely stigmas of Crohn's in the terminal ileum, and we do not see celiac, we do not see TB, we do not see and.
So at this stage, we thought, is it TB or Crohn's and TB? Prof, think that this is Crohn's. She's so confident. But because of ascites, it's not a typical finding to find ascites with Crohn's unless they have the other explanation for severe hypoalbuminemia. So the issues, who will go with the Crohn's and treat her as a Crohn's, and who will go with the TB and treat her as a TB? We took a biopsies. Oh, okay, we did. Sorry, I didn't. Can you mention the pathology?
Okay.
Because the histology will tell you what type of granular.
Sure.
So,
okay.
This is pathology for the patient. Only cryptitis was there, and there's active colitis with neutrophil infiltrates, and there's granuloma, but not carious. There's no granuloma. There's lymphocyte infiltrate. Also, just only articular distortion. That's all over here. No caseating granuloma, no granuloma, just cryptitis and active colitis. So
that's the pathology.
That's the report of the pathology. There's articular distortion, crypt dispersion, and cryptitis, negative for crypt ascites, granuloma, or viral, negative for TB-PCR, and negative for malignancy.
Shall we treat her as a Crohn's, or you'll go ahead? Yeah. Negative. Yes. Crohn's. Okay. So this lady, what we did the same thing. We thought that's probably we are dealing with Crohn's disease. Unfortunately, she was missed for 2 years. She was wandering around. Many clinics, she lost half her weight, and we should deliver this message to the practitioners in the private sector. Sorry? Yes, she's having ascites. And that is because of severe hypoalbuminemia. The acidic fluid? I don't think that, did we take samples? No, we didn't take any fluid because she's saying severe hypoalbuminemia. We thought that's enough explanation for her ascites. We didn't take samples. I think, but you have a point. You can always take a sample.
Upper GI and duodenal were both?
Sorry?
Upper GI.
Yeah, upper GI there was nothing here. So it's mainly a small bowel, particularly terminal ileum. So I put her on a steroid and Emuran Bentasa. I saw her 2 weeks later. Totally different person. She's totally different. She started She gained like probably 4 or 5 kgs in 2 weeks' time. She's eating, the pain subsided, and she's very happy now. Me also, I'm very happy for her.
And it helped our depression.
Sorry? Sorry.
I think I agree with you regarding the message for how to pick up the IBD patient and how to maximize the treatment. So most of the cases, like getting around or shopping between the clinic, they are undertreated or underdiagnosed. I have a patient yesterday, she is on steroid for 10 years. So was diagnosed at age of 6 and now he's 16 and he's on a steroid. So this one probably you agree with you have to get aware about IBD management and diagnosis.
Sometimes it's very difficult to differentiate between intestinal TB and Crohn's. But I think that this is a typical story of Crohn's. The more you see of non or extra-intestinal manifestation, you probably go with fever, non-obstructing symptoms. Then probably you will go fatigue. Then you'll probably go with TB. Rather than the weight loss, the vomiting, the abdominal pain, you add to this the imaging findings too. If you have more of lymphadenopathy more than thickening, then you'll probably go with more with lymphadenopathy. You add it also to your endoscopy. If you have circular versus longitudinal ulcer, that goes with TB rather than longitudinal, which usually goes with Crohn's. In addition, also with the histopathology, they have their own also criteria differentiating Crohn's. But I think this is a very typical, ascites is a very typical also with someone with albumin of 15, unfortunately missed. Another thing that I will add, unfortunately, especially in clinics, with this H. pylori, I don't know what to call it, but business, someone will come with a respiratory infection, you do H. pylori and you treat him. This is probably treated 5 times, unfortunately, as H. pylori. And we've seen many patients with dysphagia, 50-year-old dysphagia, treated 3 times as H. pylori. And unfortunately, diagnosed like 2 months ago with esophageal CA with liver metastasis, unfortunately. It's unfortunate.
I'm going to about an excellent article by Professor Jibril and Mr. Mark 3 years ago, how we should between TB and
Crohn's. I think we should get a chance, if you can, through the Saudi GI Association, how can we increase the awareness of the general practitioners and those who are seeing patients in the private sector about the diagnosis of IBD? Because I feel really sad for this young girl. 2 years she is missing around. How can you do that? Is there any chance that we can do it?
IBS or
Depression, IBS, gastritis, you mentioned it.
I think the general practitioner nowadays, they have a chance, they improve even himself in terms of, now you have also the stool calprotectin can help you a lot whether the patient is having something active or not. They can do the marker for the inflammation. It's unusual for, it is very unusual. I know the GB may see a lot of IBS, and that may make them just like routinely, patient come from the door, IBS, proof otherwise. But they have to get alarm symptoms. A patient who lost that significant weight, patient who is having low albumin, all this does not go with functional issues.
I think to improve the performance of GP or colleague in the different areas should be encouraged to come to the hospital to do rotations in the clinics, even the ward, and to be compensated even by ministry for any reason. I think this is the only way or good way to improve the performance of them. Many times patient with chronic diarrhea and they are given, for example, flagyl, and it already is not acceptable and should come to the clinics.
Any questions, any comment? Thank you very much and have a good evening. Thank you.